start the live demonstration of the 2D ultrasound, transvaginal. Now before we start to do the transvaginal process, we must know about the history very carefully. Most important, the last menstrual period. Is she on any medications? Is she taking oral contraceptive pills? Because that can affect your endometrium. Is she on clomiphene citrate? And more important, does she have any allergies like latex allergies? And we must always take the verbal consent before doing the transvaginal ultrasound. Patient should be explained what the procedure is going to be. Tell her what the position is going to be, how we are going to insert the probe, and why we are doing this. After explaining everything, we take the position of the patient. A little bit about the machine. This is the Hitachi Aloka. You can use any good machine. This is the 7 megahertz transvaginal probe. This is the transducer tip. This is the angulation in which we know the direction of the probe, and there are a few things that we need to know in the probe while we do the scan, in which we have, this is the depth and the zoom and the black and white gradations that we should know. This is the depth and zoom. Please put the probe. And this is the brightness. This is the cursor. So these are the few things that we must know while we do the transvaginal scan. Insertion of the probe is very important. We must be very gentle while putting in the probe. So we have used a non-spermicidal cover, and we have used normal saline for lubrication. Now the most important thing while we do the ultrasound is to get the sagittal view. Are we getting both the views? Yes. So once we get the entire sagittal view right from the fundus till the cervix in the same line, that is where we must measure the endometrial thickness. So for example, in her case it is 9.4. This is the 14th day of her cycle. And once we have seen the sagittal view, we would like to go transverse and go up and down. Now this is a very important view for ruling out uterine anomalies. Your septate, your double uterus will all come in the transverse view. Once you have gone into the transverse view, then you move into the adnexa. As you go into the adnexa, you can see the ovaries. You may want to zoom out. And again you need to go back to your sagittal if you want to go relocate yourself and go to your transverse view, and then go into the other adnexa. In the other adnexa, we can see the lead follicle, and that has to be measured in both the directions, and then you have to measure the dominant follicle, the dominant follicle is usually very regular, and while we go to the Doppler session, we can find out that putting a Doppler on your follicle may give you a good idea as to how good the egg in the follicle is. A Doppler flow of more than 10 centimeters per second gives a good idea of the follicle. Now let us see what the next patient has in store for us. So, transvaginal ultrasound has a megahertz of 5 to 7.5 and transabdominal between 3 to 5. Now, the resolution of TVS is very high, but the field of view is small. So, like for example, if there is a big fibroid, you will miss it in your transvaginal scan. And so, it is always a good idea to do a transabdomen after you've done your TVS. Now, TVS is always done in an empty bladder, and suppose there is a large fibroid, you can pick it up even when you do not have a full bladder. So, the rationale of doing a transabdomen after a TVS is to pick up large cysts, large fibroids if you have missed it in your transvaginal scan. And as has been discussed, this is the probe and there is always a transducer tip and a transducer mark. The transducer mark has to be in the 12 o'clock position, and then it has to be moved right and left to get the sagittal view, and then you turn it either at 3 or 6 o'clock position, which I shall demonstrate in the next patient. Please put the probe. Put a jelly. So, while I was explaining that suppose you have held your probe and the 12 o'clock is in front, this on a right and left motion will give you the sagittal view. The same if you turn it 90 degrees, your aligner will come either in the 3 or the 6 if you turn it left, depends on which handed you are, and then you get the entire transverse view. And then if you move right and left, you will go into the adnexa. So, these are the basic hand movements which I shall show in the next patient. What is the LMP, please? Doctor? Okay. So, the probe is inside. We have adjusted the brightness and the depth. So, if you see, this marker is on the top, and when it is at the top, we are getting a full sagittal view. And I am going right and left to see which is the thickness of, which is the plane in which I will measure the thickness. Now, I will go 90 degree and I will get the transverse view. So, this was straight, this is 90 degree, and then I go up and down. This is a very important step, and sometimes arcuate, septate and didelphys are missed because this step is not done. And then you go to your right. So, this is the patient's right, and we see the, but your probe is to the patient's left. This is one dominant follicle and this is the other. As you can see, now if we look at measuring, this is the dominant follicle, the antral follicle count is always measured in the initial part of the menstrual cycle, because we do not want any dominant follicles to obscure our view. However, the patient, for the patient friendliness, at any point in the menstrual cycle, you can measure the antral follicle count, and the antral follicle count less than 4 is considered poor, and more than 12 is considered with risk of ovarian hyperstimulation. Now, if you see, my hand is to the patient's right and I am looking at the left ovary. If somebody can freeze the frame. Yeah. And here I can hardly see any follicles in this ovary. So this is just one small, you have to measure, they have to be between 2 to 10. And this is the other one. So are we on 2 screens? Has it just started? Okay. So this is 1, 2, 3 and 4. So these are the very small. So 2 to 10 is this. The smaller ones less than 2 mm need not be measured. So obviously, as we can see, the egg reserve of this patient is low. Now while we go into, this is the dominant follicle on the other side, and if we always I zoom out to be able to see the peritoneum as well. You know, if your view is too big, then you might lose certain adnexal features. So it's always good to zoom in zoom out and make the uterus and ovaries little small, so that the iliac, any peritoneal adhesions, any hydrosalpinx, etc. can be seen. So again in this we see the endometrium does not look too good. We will measure in this plane. Can we freeze and measure? Please measure. So while we go into the findings of the next case, we will discuss a few points on measuring antral follicle count. So antral follicle count is a very important measurement in transvaginal scan. So it is said to be the total number of follicles measured between 2 to 10 mm just in the initial part of the cycle post-menstrual. There is another concept called follicle number per ovary, and there is a consensus that more than 20 in each ovary is an indication of hyperandrogenism. And then there is another consensus which says that more than 20 in both ovaries, antral follicle count, is an indication of high incidence of ovarian hyperstimulation. So we make it 20 count of antral follicle count as a risk of ovarian hyperstimulation, and less than 4 AFC as risk of poor ovarian reserve. So quickly going through all the points, if it's of the opposite sex, it's always good to have an attendant with you, and you have to prepare the transducer well, go into the sagittal plane, then the transverse plane, then the right and the left, and a gentle withdrawal of the transducer. So the findings and the angles in which we measure the endometrial thickness is measured, and in the transverse plane we have seen both. Okay. Now again this is a patient, we are seeing the sagittal view, the transverse view, and on the right ovary we can see the various small multiple follicles, and on the left. So if we freeze it, can we zoom out? Yeah, thank you. Sorry, yeah. The uterus is coming and that. So I am counting 1, 2, 3, 4, 5, 6, 7, about 8, 9, 10. I would not really categorize it as but here you can see around the chain of cysts in the periphery. So maybe mildly polycystic, though there is no ultrasonic differentiation of mild, moderate and severe. It either has to be more than 10 on each side, and which I think we can see. And then again you scan through the endometrium to see whether you are missing anything or not. Okay, now PPT. We will. So the gradation of the endometrium is also very important. So it is divided into type A, type B and type C. The type A is where you have an intrauterine midline and it is divided. It's a very clear triple layer. Type B is where it has become little irregular, and type C is where it has become homogeneous hyperechoic with no intervening line in between the two layers. This depends on which phase of the cycle you are, follicular or proliferative, and it also indicates the receptivity of the endometrium. A triple layer endometrium is one of the best, more than 9 millimeters, is considered very good for implantation. It does not mean that if there is an endometrium which is less than 9 mm, it will lead to poorer implantation. However, we have done transfers in even 6 millimeters, 5 millimeters, and got pregnancies in some where we could not get it more than 5.5 or 5.6, but very, very few cases. Most of the results we get when the endometrium is more than 7 millimeters. Now we are going on to the next case, and she is on her 10th day of the cycle, and we are doing a transvaginal scan to see her follicle. Now, as you can see, there on the right side there is a follicle that is forming, and on the left it is just polycystic with no dominant follicle. So while we are doing follicle monitoring, it is very important to do the first baseline scan. The baseline scan should ensure thin endometrium and no cysts in the adnexa. And then the next scan is done around the 7th to the 8th day, followed by depending on the size of the follicle. Please freeze. So for example, if in this the follicle is measuring on two planes, on this plane it is 14 and on this plane it is about 17. So about average is 15. So as soon as the follicle reaches about 16 millimeters in size, then we must do daily ultrasound till the point of ovulation. PPT. We are discussing follicle monitoring while the next patient is getting ready. Now, as you have seen, one quick ultrasound will take about 2 minutes if you know what to look at. You do your sagittal view, you do your transverse view, you go into the adnexa, you look at the endometrial thickness, polyps, fibroids, uterine malformation, ovarian size, antral follicle count, any dominant follicle or not, adnexal pathologies like Hydrosalpinx, fluid in the peritoneum. So all this, if you really know what to look, will not take too much of your time. Now for example, let us look at endometriosis. Endometriosis has this ground glass appearance, and while you are going through it, you will not miss an endometrioma. Similarly, a dermoid will have hyperechoic shadows, then therefore you will also not miss a dermoid when you see one. So now in the next patient, double, we are going to see whether we have any interesting finding or not. Again, it appears like a polycystic ovary. There is a follicle on one side. This is okay, yes. So if you go through it very, very carefully, and sometimes you may need to reduce the light in your ultrasound machine. So please freeze. So at the fundal edge, I can see something. It is 0.4 millimeter. It's an endometrial polyp. Please freeze. And at the mid cavity again, I can see it is about 1 centimeter. And there is another one. This probably, let me measure it and then check again, 0.5. So yeah, so there are the 3 polyps. One is 0.4, one is 0.5, one is close to 1. And I'll check in the transverse plane. I'm a 2D person. I do not apply too much of color or 3D, and therefore I have invited special faculty to speak on their advantages and disadvantages. Right. PPT. So discuss about the polyps. So polyp, if you can see, yeah, on the screen it will appear usually as a hyperechoic shadow, and you have to again see it in both the planes. Now most of the polyps are, we do not need to do anything about it, because women can conceive with small polyps, and it could just be endometrial irregularities. However, if there are polyps that are more than 2 centimeters, this is the cutoff usually, polyps that are more than 2 centimeters need to be removed for fertility treatment. There is debate regarding polyps between 1 to 2 centimeters, and less than 1 centimeter usually can be left alone. However, if you have a patient with multiple IVF failures and there is a 0.9 millimeters fibroid and you are planning to do a hysteroscopy, I would definitely remove that polyp. Let's see what our next patient has in store. Okay, so now Hydrosalpinx we have discussed is one of the important findings which changes the IVF outcome significantly. So the ways in which we can pick up the Hydrosalpinx is either a fluid in the endometrium or a cogwheel or a tobacco pouch mass in the adnexa. So I am going through the entire, can we have the jelly ones please? You need to, if your view is not as good as you feel, then you need to check your lubrication, your machine settings, and sometimes when the uterus is retroverted, you may not get as good a view as you want it to be. So in this patient, we had fluid which I am trying to see, and at least there seems to be a hyperechoic shadow in the middle of the cavity, but there is no specific fluid at the moment. What I can see here is the iliac vessel, which I am trying to show. Very important to pick it up in the 2D. And when we do the ovum pickup, being able to identify the iliac vessel is very important. Most people would put in Doppler to check. So it is there, if you can see at the top of the screen. Now if in certain planes this looks like a follicle or not a vessel or a cyst, and while you are doing an egg pickup, especially for thin patients and where the number of follicles is less, you might injure, go directly into the vessels. And for beginners it's very important to be able to identify the iliac vessels before they do any interventional procedure. Right, so in this we have seen the lady, the endometrium was about 6 millimeters. It was type B. This is her right ovary. I can see about 2 or 3 antral follicles. This is the iliac vessel on the right side. And if I go into the other side, very small antral follicle. Right. So this lady a few weeks ago had typical Hydrosalpinx PPT, and as we have seen that, can you reduce the echo? Hydrosalpinx fluid may come and go, and you have to check a patient in 2 phases. One is during the early part of the menstrual cycle and one is mid-cycle, to first see that there are no cysts, then the endometrial thickness, then polyp and fluids. So we hope we get a patient where I can show you Hydrosalpinx. While we go back to endometriosis. In endometriosis, because we get a lot of patients with repeated IVF failures who have got laparoscopy done earlier, we usually go ahead with IVF without doing repeat cystectomy if it has already been done. The indications where we do cystectomy would be a young patient, no laparoscopy done in the past, and other factors like the tubal patency and semen analysis normal. In all other cases, older patients, endometriotic cysts coming back again and again, we would, and with other factors like tubal block, low ovarian reserve, we would go directly with IVF. Now in this, while we do the ovum pickup, during the procedure I shall show you how we try to avoid the endometrioma, and it is a cause for pelvic infections during ovum pickup as well. Okay, so this is on the left side. We are seeing a clear cyst and another cyst. Now how we differentiate a cyst from a follicle is something we will discuss. This is the left ovary. And that is the right. Is she on any stimulation? No. Okay, now freeze this view. So in this we are going to discuss, can I have single view of the ultrasound while the patient can be changed? Single view of ultrasound? Yeah. So in this we are going to show you, if we can see here, it is a globular uterus. A globular uterus is usually indicative of adenomyoma. And in this you see that the myometrial thickness is more than usual. The junction between the endometrium and myometrium is not very clear. And we shall come to other points of adenomyosis soon. So adenomyosis is basically ectopic endometrial glands, and ultrasound findings can be echogenic striation, myometrial cysts and myohyperplasia. Now this can be due to thickened inner myometrium, myometrial thickening and enlarged globular uterus. So usually the prognosis of adenomyosis depends on multiple factors. If the lady is young and there are no other associated factors and the adenomyosis is not stage 3 or stage 4, the staging of adenomyoma is done based on the number of cysts, the volume of the uterus and the endomyometrial junction. The confirmation of adenomyosis is sometimes done on an MRI. So younger patients do well, understandably, but older patients, their prognosis, especially with dwindling egg reserve and poor implantation because of adenomyoma, is less. So 2D actually, you will have to do multiple scans to get a good idea, grasp over 2D scanning, because the clarity comes with doing multiple scans. And when you add 3D and color, as you will see in our consequent lectures, the clarity becomes better. However, the disadvantage of 3D and color is that you need special equipment and you need special expertise and training for 3D and color. So in adenomyosis, as you see, in this the zone is thickened and it is globular with cyst inside, and how the MRI is giving more clarity as we move on. Okay, so now here you can see the fluid in the cavity. I want only ultrasound. And we can go to the transverse, and there on the top right corner you can see the fibroid staring at you. That's the ovaries there. The next ovary. So the sagittal view gives me the endometrium with the fluid and the fibroid. Freeze. So as you have seen, the fibroid, we have got the better view on the transverse, and it's a class 5 fibroid. So let us look into, we need to discuss about the cyst, the fluid in the cavity and the fibroid. So while I was talking to you, about the fluid in the cavity. There's still echo, please reduce it. Okay, so the fluid in the cavity comes either because of menstrual blood, hydrosalpinges, or pelvic infection, or during stimulation, which the stimulation fluid settles on its own. The menstrual fluid will settle on the 7th or 8th day. Pelvic infection and hydrosalpinx will come and go. So, to assess a patient, it is never a single scan. You have to do it at least twice over a period of time to confirm all your diagnosis. The next thing is about the follicle and the cyst. Usually the cysts will stay in the beginning part of the menstrual cycle, and they will stay constant throughout the menstrual cycle. The follicle will only develop during the early follicle phase, and the size will increase and will collapse after ovulation. So, if you are doubting whether it's a cyst, and especially if it is clear like a dominant follicle, then you have to do it over a period of time to confirm that. The other advantage of real-time 2D ultrasound is the sliding pelvis sign. For example, if we see an adnexal pathology and we are not sure whether it is attached to the ovary or it is a separate structure, then we can move the adnexal masses with your other hand, which I shall show in the next patient, to get the advantage of real-time ultrasound compared to recorded versions of ultrasound being sent to a radiologist for reporting. So, fibroid, as we have seen and as we know, the FIGO classification is usually followed. So, you have the 0, 1, 2, which is the submucous various types, 2 to 5 the intramural types, and 6 and 7 the subserous types. What we just saw was a 5 fibroid, class 5, and even here we are seeing a class 6 on your screen. The top one is about 5 and the one on the lower half is 7. If you can see the we need the two shots. Now the importance of this is what I explained in the beginning. Now let me zoom out. Okay. So this is a large fibroid. In such patients, suppose you have zoomed in, you will not be able to make out. You will just see a mass and you will not be sure whether it is adenomyosis or what. So, when there are large masses, always zoom out and always follow it with a trans abdomen, even though she does not have a full bladder. Now, can we change the settings to trans abdomen? Only ultrasound? Just from ultrasound, we are checking on the tummy to see the fibroid, only ultrasound. And there is
presentation. Jammu Medical College 40 minutes
So this lady had a fibroid of about 6 centimeters, but suppose it is an 8 to 10 centimeter fibroid which is not coming in your view, then a trans-abdomen confirmation even with an empty bladder will suffice. This is just to demonstrate that we can have a transabdomen for lower, for higher masses. Now if on the sliding, can I have the probe? Can I have double picture of my hand, just my hand. Now this is, suppose the probe is inside and I have seen single hand. So I can put one hand on the abdomen, press it and then go up and down to see whether the pelvic structures are stuck or whether they are free. This is the advantage of doing a real-time 2D ultrasound to differentiate hydrosalpinges, ovarian cyst, adhesions, stuck fibroids, etc. PPT. Right. So now we are almost to the end of our demonstration. Let me just quickly go through the uterine anomalies. Now the anomalies, again and again I am referring, because septate and double uterus, though they do not cause reproductive issues, but in those that there is infertility and there is a large septum, according to us, and there have been many studies that have confirmed that large septum, that means a septum going more than 50% of the cavity with reproductive issues, must be removed. So for that, diagnosis is important. If there is a diadelphys, then you will see two endometrial lining throughout the cavity of your transverse scan. If you can see the picture next. So you can see this. So you are scanning it both in your transverse, and this is the longitudinal view. Right. So that was about our anomaly. I hope we can find one. And the adnexal we have revised. Right. So after this presentation, we can have discussions during while we change the patients for the next 2-3 patients. So can we have the other slide? See, this is your sagittal view, and in this I cannot see much. The things at the lower half are basically probably some vessels. Bhavna. And this is my adnexa. There is a collapsed cyst here. Now I am turning my probe 90 degree, and there I see the fibroid sitting there. Color. So if you see this view, this is my transverse view. So I have the endometrium here, and on this side is the fibroid. So it is pushing into, but not yet reached the endometrium. Color. So this is the fibroid here, and this is the endometrium. There is another, that was an intramural fibroid, and here there is a subserous fibroid. Measuring about 3 centimeter. right ovary, left ovary with a single dominant follicle.